Good evening, everyone, and welcome to today's smart learning session of the ISU. And we will be having two speakers to speak about very important topics. The first being Dr. Prashant Nayak. Dr. Prashant Nayak is the additional professor of urology at AIMS Bhubaneswar. In addition, he is the educational chairman of the female and functional urology section of USI, and he's also a council member of the same. We welcome Prashant, and I request Navneet ji to please start his presentation.
Thank you. Good evening, everyone. Today I'm going to speak about a topic which is not talked about much nowadays. I'm going to be talking about the TURP syndrome in the new age of bipolar resection and about laser resection. Probably this has been relegated to the dustbin and this topic is not often talked about. So, but there are scenarios where we still, or many urologists will still have to resort to doing resection using monopolar energy. So this is of relevance at that time, and we need to speak about it and at least know about this entity, which is the TURP syndrome. So I'm Dr. Prasant Nayak. I'm additional professor at AIMS Bhubaneswar, and I will be speaking about this. So yeah. So what is the definition of a TURP syndrome? So it's an iatrogenic form of water intoxication, and it's a combination of fluid overload, where a lot of fluid gets absorbed, that leads to a dilutional hyponatremia, classically seen after TURP, especially monopolar TURP, where a large amount of irrigating fluid gets absorbed and leads to various systemic manifestations. So a significant irrigant fluid absorption occurs in about 50% of all TURPs. Of them, about 5 to 10% absorb more than 1 liter, more than 1 to 1.2 liters is observed, and in about 2% of these patients, they manifest with a TURP syndrome. So 2% of patients overall who undergo monopolar TURP, and they will manifest a TURP syndrome. The mortality of TURP syndrome is low, also only about 0.2 to 0.8% of all patients who manifest TURP syndrome. This syndrome generally manifests within 15 minutes, so it can happen intraoperatively, or it can start happening up to about 24 hours post-operatively. Where does this irrigant go? So talking about this irrigant getting absorbed, irrigant gets absorbed in the prostatic venous sinuses into the prostatic veins. It can go through the breaches of the prostatic capsule or the pseudo capsule into the interstitial tissue, into the retroperitoneal, into the extraperitoneal, or sometimes even intraperitoneal. If there is intraperitoneal injury or rupture, so it can get absorbed intraperitoneal. So these are the various places where this fluid gets absorbed, and from there is systemic absorption, leading to a significant overload of fluid as well as hyponatremia. What's the ideal irrigation solution? It should be isotonic, it should be electrically inert, it should be non-toxic, it should be transparent so that we have a good vision, and of course it should be inexpensive, but it is difficult to find the ideal one. So what are the various solutions that we have? So we have got glycine at 1.2, 1.5, sorbitol, mannitol, cytol, glucose, urea. These are the various things that have been used. Glycine 1.5% is probably the most commonly used irrigant during monopolar TURP. It has an osmolality of about 220 milliosmoles per kg. The normal blood osmolality is somewhere between 270 to 300 or 270 to 295 milliosmoles. So this is the one that is closest, but still it is significantly having a lower osmolality compared to the blood. NSRL, of course, is an ideal solution, cannot be used for monopolar TURP because the current gets dispersed. So that is not an issue when you're doing a bipolar TURP, but for monopolar TURP, NS or RL cannot be used. What are the signs and symptoms? So when I say that a patient had developed a TURP syndrome, so what are the various signs and symptoms that the patients manifest with? So it could be divided into the CNS signs and symptoms, cardiovascular and respiratory symptoms, and metabolic and renal symptoms. CNS symptoms could range from restlessness, headache, confusion, convulsions, coma, visual disturbances, nausea, vomiting. Serious respiratory, lot of fluid gets absorbed. Patient may have hypertension, can have tachycardia, tachypnea. There could be an interstitial, there could be pulmonary edema, there could be hypoxia, so tachypnea. And hypotension also occurs because of that excessive fluid overload. Cardiac toxicity occurs, and hypotension, bradycardia could also occur. Next, coming to the metabolic effects, the patient would have hyponatremia, as I said, because of excessive fluid overload and dilution. Would have hyperglycemia because there's 1.5% glycine solution that you're using as irrigating solution that gets absorbed, and glycine get converted into various toxic metabolites, and that could lead to side effects because of this. There will be intravascular hemolysis, and patient may end up with acute renal failure. What are the signs of water intoxication? So it's a neurological disorder due to increased water content of the brain. Patient generally presents with increased sleepiness or somnolence. Then patient has incoherence, and then he becomes restless. It could lead on to seizures, coma. Patient could present in a decerebrate position where when you examine him, the clonos and positive Babinski responses would be seen. When we examine these patients with water intoxication, they might have papilledema with dilated, sluggishly reacting pupils. If you do an EEG, we'll find a low voltage on both sides, on recording from both sides of the skull. These features generally appear when the serum sodium falls about 15 to 20 milliequivalents below the normal. Hyponatremia, again, a little bit explanation of each of the various things that I talked about. Hyponatremia, again, excessive absorption of irrigating fluid, loss of sodium or escape of sodium into the irrigation fluid that is used. So from the interstitium, from the tissue, the sodium get directly lost there. Loss of sodium and this fluid into the periprostatic and retroperitoneal space can occur. And large amount of glycine also stimulates ANP, so that leads to natriuresis. Right. So symptoms of hyponatremia: restlessness, confusion, incoherence, coma, seizure, these would be there. Less than 120 milliequivalents, patient initially has hypotension, reduced myocardial contractility. Less than 115, patient can have bradycardia, widening of QRS complex. Ventricular ectopics could show and P-wave inversion. Less than 100 milliequivalents per liter. More serious complications like seizures, coma, respiratory arrest, ventricular tachycardia, cardiac arrest, these are the things that could occur. Glycine, as such, when large amounts get absorbed, it can depress the myocardial function. So 0.5% of these patients would develop an acute MI during TURP. There is some data to say that about 20% of all patients who undergo monopolar TURP have some kind of transient MI. So this, I was also surprised when I was going through the data, but this has been recorded, and they find cardiac enzyme elevation in up to 20% of patients. And these patients would also have a dilutional hypocalcemia, but calcium is restored rapidly, so it gets mobilized. So generally, we do not see the consequences of hypocalcemia. Glycine, in addition to the other effects, it's a major inhibitory neurotransmitter. So a lot of glycine gets absorbed. It will also affect or depress the CNS function. I talked about the various metabolites of glycine like glycolic acid, formaldehyde. This would have a direct impact on the vision, and so patient would have visual disturbances. The various other features will be nausea, vomiting, slow respiration, seizures, apnea, cyanosis, hypotension. So it has been seen that when you add arginine, somehow the toxic effect of glycines are ameliorated to some extent. Exact mechanism is not known, but I will be talking about a putative mechanism, how arginine decreases the TURP syndrome or the decreases the glycine toxicity. Ammonia is a major metabolite of glycine metabolism. High ammonia, it suppresses the norepinephrine and dopamine release in the brain. It could lead to an encephalopathy of this TURP syndrome. So hyperammonemia, once it's there, it lasts for about 8 to 10 hours. Glycine, because the glycine continues to get absorbed from the interstitium and the periprostatic tissues, and it continues to lead to a hyperammonemic state that leads to an encephalopathy. Ammonia toxicity possible explanation is deficiency of arginine. So ammonia is generally converted to urea in the liver, but if arginine is an important intermediary product that is necessary in this conversion of ammonia to urea in the liver. So if patient is arginine deficient, this doesn't happen and hyporemenemia occurs. So this is possible mechanism why if you supplement arginine or give arginine along with glycine, probably the side effects would be lesser. Coming to hypovolemia and hypotension, this could be due to absorption of this prostatic tissue fragments, endotoxins, and this metabolic acidosis. Again, blood loss could be there. Blood loss is a significant part of URP. About 10 ml per gram of resected tissue is the estimated blood loss. So if there is a large prostate or operating for a longer time or adequate skills are not there, this could lead to a increased amount of blood loss. Visual disturbances, transient disturbances generally come back in 8 to 48 hours. These are generally due to a retinal dysfunction because of glycine toxicity. There is an entity called URP blindness. The way to differentiate it from cortical dysfunction and leading to blindness versus a local ophthalmologic or retinal dysfunction leading to blindness is that the perception of light and blink reflexes they are reserved in TURP blindness due to retinal cause, and the pupillary responses to light and accommodation they are lost. Right. So coagulopathies could be another complication, generally due to DIC and dilutional thrombocytopenia. Now coming to this slide, this was an algorithm that explains most of the things that I have been talking about. That this URP syndrome is due to three components. One is irrigation or absorption of a lot of fluid, solute changes, and the presence of hyperglycemia or glycine and its metabolite like ammonia. So hypervolemia leads to hypertension, bradycardia, left ventricular failure, increased capillary leak. Again, all of them lead to hypotension. Hypovolemia again can lead to cardiovascular collapse. Solute changes can like hyponatremia, hypoosmolality, contributing to pulmonary edema, leading to respiratory failure. Again, respiratory failure can lead to cardiovascular collapse and ultimately could lead to death. And glycine and its metabolite would again contribute to visual changes and encephalopathy leading to death. So other effects also are explained like hemolysis and cerebral edema could be due to the hypoosmolality. Risk factors for all this is increased surgical time, keeping the irrigating fluid at a great height more than 60 centimeters. This is a rule of 60, operating more than 60 minutes with a bag of at a height more than 60 centimeters, resected weight more than 60 grams could increase the risk factors for this TURP syndrome, especially if it is associated with large amount of blood loss or there is pseudocapsule perforation, large amount of fluid has been used, patient had a pre-existing congestive heart failure or CKD. These are all various risk factors. How much of fluid is necessary when you're doing a TURP? So generally 300 ml per minute of fluid is necessary while irrigating to have a good vision. And irrigation fluid, if you keep it at about 60 centimeter height, it delivers about 300 ml per minute. So ideal height is about 60 centimeter height. What are the various prophylactic measures that we can do against URP syndrome? You should correct the pre-existing hyponatremia, central venous monitoring, especially in those patients who are at higher risk. So that is ideal. Ideal irrigating height, as I said, is 60 centimeter. Duration should be restricted to 1 hour. If there's a larger gland, you could do a staged procedure rather than trying to complete everything in one go. Try to preserve the prostatic capsule. Do not overdistend the bladder. Again, this could lead to more absorption of fluid. And continuous flow methods have been shown to be probably better as compared to an intermittent flow methods. And serum sodium could be estimated in between if required. Optimum fluid therapy should not do push in a lot of IV fluids. If required, we could manage with some kind of diuretic therapy in between. So prophylactic furosemide could be used. If we need to give a blood transfusion, again, packed cells is better because that gives less fluid into it. Increase the atmospheric or the ambient temperature of the OT should be kept optimum so the patient is not having hypothermia. And of course, the use of bipolar TURP or laser, especially in larger glands, would avoid this TURP syndrome to a large extent. The regional anesthesia without sedation, what is called awake TURP, is probably better because early manifestations of this TURP syndrome would be recognized. And also, regional anesthesia leads to some amount of peripheral vasodilatation that minimizes the circulatory overloading that occurs due to absorption. And it also provides some degree of post-operative analgesia. So bloodless will be less with that, and this neuroendocrine and immune responses are preserved with regional anesthesia. So if you have any indication that patient is getting into this TURP syndrome, you should immediately abandon, or surgical procedure should be terminated after achieving hemostasis. Stop giving a lot of IV fluid to avoid fluid overload. Furosemide or some loop diuretics could be administered at 1 mg per kg, but the disadvantage of this loop diuretics is also increases the sodium excretion. So there are studies which say that probably 15% mannitol is a better choice, where the diuresis is independent of sodium excretion. Oxygen should be administered, and pulmonary edemas should be appropriately treated, and patients should be adequately investigated with ABG, hemoglobin, serum, sodium. Hyponatremia, if it is a patient has mild symptoms, sodium is more than 120, generally fluid restriction with NS supplementation and loop diuretics, fluid restriction and NS would work depending on whether it's a euvolemic, hypovolemic or hypervolemic hyponatremia. Severe symptoms, patient at less than 120 milliequivalents per liter, we could consider using hypotonic sodium chloride at a rate of less than 100 ml per hour, and we should discontinue if and when the sodium crosses 120 milliequivalents per liter. In a 24-hour period, we should not aim to increase sodium more than 12 milliequivalents per liter, because too rapid correction would lead to a pulmonary edema and central pontine myelinosis. So significant blood loss can be corrected by giving packed cells. PIC should be adequately treated with a combination of fibrinogen and heparin. FFP and platelets could also be administered depending on the coagulation profile. So that is a rough overview of TURP syndrome, its manifestations, and its treatment. So this is probably the last slide that I want to talk about. This is a World Journal of Urology article from 2022 March that talks about irrigation fluid absorption during transurethral bipolar and laser prostate surgery. So all this while I've been talking about monopolar TURP, but this syndrome can occur and does occur even with bipolar TURP and laser prostate surgery, because the mean and maximum irrigation fluid absorption during bipolar TURP could range between 133 ml and 115 ml, and maximum could go from 1 liter to 2.5 liters or 2 liters. So with such amount of large fluid gets absorbed, at least the hypervolemia contact, the component would still be there. So that is even if you're using MS. So that could lead to a TURP syndrome like picture. And they have also seen that during laser procedures, they have achieved this irrigation fluid absorption up to about 4.5 liters. So especially when you're using a laser vaporization procedure. So this could lead to a large amount of fluid absorption up to 4.5 liters. So incidence of moderate to severe symptoms from isoosmolar, because this NS that is used, volume overload, could reach about 9% even in bipolar TURP and laser TURP. So this was a article that came out in World Journal. So that is why we all should know about this syndrome, although it is the severity and incidence is less after bipolar and laser. This is not unheard of in these times. Thank you. Thank you for your patient listening, and hope this has been of use to everyone. Thank you.
Yeah, thank you, Prashant. I'm sure all of us have memories of one or two TRP syndromes which we have experienced in our lifetime, and they were just a very horrible experience to remember. And I definitely shudder on the idea of the TRP syndrome, which happened in my life during residency. However,
Hello.
Ma'am, we
Hello.
can't hear.
hello.
Yeah, ma'am. We can hear you.
Prashant, are you there, Prashant? Prashant? Prashant?
Wala sir, shall I start?
Yeah.
Means,
Yeah.
Prashant has to be unmuted, Navneet. Yeah, Prashant, can you hear us?
Yes, sir. I can hear you now. I was not being allowed to unmute. So that was the
Okay.
issue.
Yeah, Prashant, one question which is frequently asked by the examiners to the students,
Yes.
that what is the earliest sign of URP syndrome in a patient who is being attended in the general anesthesia, or if
Yeah.
it
So
is
actually, as I mentioned, this is about increased sleepiness or somnolence. Patient will start yawning. So when the patient is on OT table, if he starts yawning excessively, so that is probably one of the earliest signs that you could recognize. So that is to pick it up. So that is the yawning or somnolence, which is the earliest sign. So.
And what about if the patient is under general anesthesia? How we recognize?
So again, general anesthesia, you will have features of this hypervolemia. Lot of fluid is getting in. Patient will have hypertension, so BP is going up. So these would be the early signs that probably the anesthetist would alert you that that this is happening, and you will have to check what is the reason.
Thank you, Prashant. Over to you, ma'am. Madam, over to you.
Sir. Yes. Yeah, thank you, sir. So I would like to introduce our next speaker, who is the president of Urology Society of India, Dr. Sanjay Kulkarni, and he is a renowned reconstructive surgeon. We all know him very well, and obviously, all of us are waiting to hear him speak on a topic which is pretty uncommonly seen by a general urologist, and definitely such patients must be being referred to him, and that is why he has so much experience in this topic. And I request sir to please start his lecture on post-URP strictures.
Thank you. Thank you, Dr. Sujata Patwardhan and Dr. Prashant gave a very nice review of post-TURP complications, post-TURP syndrome. I'm going to discuss about post-TURP stricture and incontinence. Thank you, Dr. Arun Chawla, for asking me to give this talk. So we opened this 100-bed urology institute in Pune 1st of January this year, and we perform world's largest number of urethroplasties. I just want to tell you that every week we do 1 to 2 post-URP stricture repairs. So I have taken this a little broad sense. Urethral stricture after prostate treatment I have taken, not only TURP. So benign prostate, we perform TURP, unipolar, bipolar. Laser vaporization is now going out of fashion, but laser enucleation is coming into vogue now, thulium and holmium-5 lasers. And then open prostatectomy is now being replaced by a robotic prostatectomy for really very large glands. Now, when it comes to prostate cancer treatment, which I have included in this talk, is post-radiation, post-HIFU, and post-radical prostatectomy, we get bladder neck stenosis. So I have really taken all the prostate problems. So I just want to go through the history. When my guru, Richard Turner-Warwick, was doing open surgery for BPH, you can see the finger is moving between the apex of prostatic urethra and the beginning of membranous urethra. So whenever the surgery is over, the bladder neck is gone, and the sphincter is prostatomembranous. This is very important. The sphincter is prostatomembranous. And so this is a slide on the left. If the patient develops some narrowing at the prostatomembranous junction, if you try to do DVIU, then there is a chance that the patient may become incontinent. So the treatment advocated by Turner-Warwick was gentle dilatation. One must understand this concept. Now what happened? We shifted from open surgery to TURP. And we kept on saying that this is a post-TURP sphincter stricture. So we know that it's a proximal bulbar stricture as shown in this RGO on the bottom right here. And whenever we do DVIU, dilatation, or ventral buccal mucosa urethroplasty, the patient doesn't become incontinent. The second site of stricture is penoscrotal, third is meatal stenosis. And this is important for us to understand the difference between open prostate and the endoscopic prostate dissection. So we wrote an article in 2019, Management of Post-TURP Strictures. This is a World Journal of Urology. One site, this is meatal, submeatal, penoscrotal, especially if you do give a lot of traction postoperatively, then and if you have to go in again in the evening for clot retention, then you can see there is a trough created at a penoscrotal junction, and the last site is the proximal bulbar. So 3 sites are seen commonly. What's the incidence of post-TURP urethral stricture? It varies between 2.2 to 9.8. I think it's about 10% in India. It's very common. And this is from James Rasfeller, 2006, in European Urology. And the incidence of bladder neck stenosis is about 0.3 to 9.2%. So incidence of post-TURP urethral complications is really significantly high. As I said, site 1 is meatal stenosis or navicular fossa. Then there is the treatment is meatotomy. In this patient, you can see there is total obliteration of the penoscrotal junction. This is the proximal bulbar stricture. And on the right, you can see a pan-urethral stricture. So 4 different scenarios, what we see after TURP. What happens? So you can see, I call it, so this is my own personal thinking about why do they develop this. So you can see there is this resectoscope, the outer sheath has a lot of holes inside. All right. And when it's a tight fitting urethra, the instruments are a little larger, then what happens? We have a cheese grater effect. That means the mucosa will bulge into the hole and you are constantly moving the resectoscope. So on the right, you can see before TURP, the proximal bulb urethra looks really well, very nice, smooth. And after TURP, what happens? We suddenly pull the resectoscope out without examining what has happened to the bulbar urethra. And then you can see that a lot of shaggy urethra here. Occasionally what happens when you introduce the scope inside, a sleeve of mucosa goes inside, and those patients definitely develop a bulbar urethral stricture. There's an article, interesting article by Oliver Traxler in Urology, The Truth About Laser Fiber Diameters. What it says, the lack of uniformity between laser fiber manufacturers, and they all lie. This is very important. That means whatever they quote is not the true figure. They are giving you only the inner diameter of the fiber, they are not giving you the outer diameter. So they say 200 micron fiber, what is quoted is 270 to 273. So this is now accepted around the world that laser manufacturers don't give you the correct figure. What we did, this is a 26 French resectoscope, and we measured actually in about 50 patients, 50 different readings by the same person. And you can see the 26 French resectoscope is actually 27 French towards the surgeon, and towards the distal end inside the bladder is about 28 French. That means we wrote an article, Are Urologists Getting French Fried? This was not easy to publish. So a 26 French TURP sheath, the true French scale circumference is about 28.25 and by diameter is 28.32. And this is common. So the 20 French cystoscope sheath is 22.6 and it can vary by diameter 18 to 24. The 7.5 ureteroscope that we use commonly is 9 to 11 French or maybe 7 to 10 French in size. That means whatever the manufacturers are telling you may not be true. So when I get a patient of a post-TURP urethral stricture, I may do single DVIU, dilatation, And then occasionally the patient refuses surgery, so I will request the patient to do self-cath, especially if he's unfit for surgery. So single DVIU for proximal bulbar stricture. If it's a meatal or submeatal stricture, then meatotomy could be performed up to the corona sulcus. I very rarely perform meatoplasty. The patient has a penobulbar stricture, then we make a perineal incision, invaginate the penis into perineum. For non-obliterative stricture, we do one-side dissection, dorsal onlay technique. For obliterative strictures, we perform double phase buccal mucosa. These are tough strictures because the recurrence rate is slightly higher than normal. Then we have mid-bulbar strictures. We have a choice between dorsal onlay, Mundy technique, then Barbagli, and Kulkarni, depending upon how complex is the stricture. All right. Now we have a proximal bulbar stricture, which is a commonest site of urethral stricture following TURP, and I will show you a video of ventro-onlay buccal mucosa. Occasionally, we get patients of a pan-urethral stricture, and we perform the Kulkarni technique by one-side dissection dorsal onlay. So this is important. Dr. Sanjay Kulkarni says that post-URP sphincter stricture is a misnomer, and post-URP strictures are close to the membranous urethra, but they are always proximal bulbar. So this is a video. This patient, you can see, has a stricture which is in the proximal bulb. The flow rate is poor, and then I'm doing endoscopy with a 4.5 or a 6 French ureteroscope. That's a Veru. I'm pulling the scope out, and you can see the membranous urethra, which is okay. And this is the proximal bulbar stricture. You can see the white area here. So make a perineal incision. The Turnavoric ring retractor is applied, and then I'm dissecting the urethra from the bulbospongy muscle. Then I pass a dilator, and I'm going to open the urethra, the spongiosa ventrally. I'm opening the urethra more distally to give me a window to have a look inside. So this is a 16 dilator, and the window created is about 1 to 2 centimeter long. Then this is a stay suture to open up the window. Little more dissection opening up distally. Here I'm going proximally. Now here urethra makes a turn. Now the urethra, rather than vertical, slowly becomes transverse. And you can see the inside, there is a guide wire going inside. I'm going to open the spongiosa for a while, but after a while, I'm going to incise only the mucosa. Now here, if I go dorsally, I have to incise the whole width of the urethra, which may jeopardize the function, residual sphincter function. So here, with the ophthalmology knife, you can see the white scar there. I'm making an incision onto the mucosa only, sparing the sphincter active urethra proximally. And you can still see the mucosa inside, a little bit of white tissue ventrally. And then now if I pull the urethra out, you can see the pink urethra. First stitch is taken at 6 o'clock, outside in. This is 50 PDS. Then I rotate the forceps, and the second stitch is taken at 7 o'clock. Again 50 PDS, and third stitch is taken at 5 o'clock. So here I want to push the buccal mucosa graft deep inside, and the idea of ventral onlay is to avoid injury to the residual sphincter function. The patient should maintain his continence. Then the buccal mucosa, the 3 sutures are taken, the graft is pushed inside, and then the sutures are tied. Next, I'm going to suture the right edge of the urethra to the right edge of the buccal mucosa. This is the nasal speculum inside, and then we can actually show the distal end of the Veru here, and we have not caused any damage to the sphincter active urethra. Now I'm going to close the ventral area with the buccal mucosa. Now this patient had a little longer, about around a centimeter near obliterative stricture, where only guide wire could go inside. So to have a look inside, I had to make an incision dorsally and then a little bit incision only onto the mucosa without harming the sphincter active urethra. A tiny piece of the buccal mucosa was taken from the edge of the longer buccal mucosa graft, and I'm going to do dorsal inlay ASOPA technique just to give us what you call a double face buccal mucosa urethroplasty. It is fixed with multiple quilting sutures, and now I'm going to suture the edge of the buccal mucosa to the edge of the urethral mucosa here, continuous quilting, continuous sutures, and then right side is finished. Then I insert a 16 French Foley catheter just to show you the suturing margin here. Then the left side, the catheter goes inside. We leave the catheter for 4 weeks in all patients. They say 3 weeks for healing or 1 week for the surgeon. We don't want a fistula here. This is the patient's left side. And now I'm going to close the spongiosa. When I close the spongiosa, I'm going to do reverse quilting of the buccal mucosa graft. I'll show you what is reverse quilting. So edge of spongiosa, back of buccal mucosa, and edge of spongiosa. This allows us to pull the buccal mucosa graft away from the lumen, and then this is how it is done. So this is a very nice procedure which I'll go to the next slide. So management of post-URP strictures, this is World Journal of Urology. And then we had our series published of 170 patients. Then the mean age was 67 years. Mean preoperative Qmax was 6 ml. And then the length of the bulbourethral stricture was about 1.95 centimeter. And then commonest site was bulbourethral stricture. And the incidence of stricture was more with monopolar and bipolar TURP. What are the risk factors for bladder neck contracture? Low resection speed, infection, intraoperative urethral mucosa rupture, and the risk of BNC is increased with small gland and worse pre-op IPSS score. This is International Journal of Brazil Surgery. The meta-analysis shows that a monopolar and bipolar TURP has a roughly similar 4.5 to 5.2% incidence of bladder neck contracture. The treatment options available for bladder neck stenosis are observation, catheterization, endoscopic treatment, reconstruction, and diversion. All of us are familiar with cold knife incision. The success rate is about 66%. And for holmium laser incision, the success has been quoted as 100%. And I have quoted 5 different papers here. So all of us are familiar with bladder neck incision and laser incision. Now, if we have a patient with recurrent bladder neck stenosis, 1, 2, 3, 4 failed bladder neck incisions by different techniques, then we do perform YV plasty. Now, I will show you this video from Kersey Lee Zhao. He is going to do repair of the bladder neck stenosis with a robot. So this is, he has made an incision onto the anterior wall of the bladder, right? And he is making a V cut here on both sides. So Li Zhao, my friend, is considered an authority on, this is inside the bladder, authority on robotic reconstruction procedures after prostate cancer treatment. And this flap is now inserted into the proximal urethra here. Now, the chance of patient developing incontinence is less because he is close to the bladder neck only. He is not going distally. And then this procedure is called YV plasty. Incision is Y and then turn it into V. And this can be done. The second procedure I'm going to show you is my friend, Dr. Dimitri Nikolowski. And now he wants to do buccal mucosal inlay. So he is making a incision at the bladder neck through the bladder robotically. And then this is one limb of the Y here. He is going to excise all the scar tissue. There are catheters into both ureters here. And then you can see he's excising the scar at the bladder neck posteriorly. The Li Zhao's approach was through the anterior bladder wall. This is the posterior bladder wall. Now, after excision of the scar, an associate will harvest a graft, buccal mucosa graft, and it is, you can see excision of the scar here, the whitish tissue, and this is BMG inlay. Now, these are common after radical prostatectomy, after therapy for prostate cancer, different treatments available, including radiotherapy, and the buccal mucosa is spread and fixed into the scar excised on the posterior wall of the bladder neck, and it is quilted there. This looks simple, not simple. Both surgeries are not simple. So this is buccal mucosa inlay. Then I go to the last technique. And this is by Jonathan Warner, another friend of mine. And he used a similar instrument, similar to what Mihir Desai used for endopyloplasty. So here he is making a lateral incision onto the bladder neck, which is stenosed. You can see the white fibers. And now with this special instrument, he's pulling the bladder mucosa, which is used by Mihir into endopyloplasty. And he is going to pull the bladder mucosa and is going to suture it down to the incision distally. Yeah. And this is an endoscopic procedure. And this is published very recently. He showed a video during AUA last year, not last year, this year only, in Chicago. So this is Jonathan Warner. This is a special instrument that he uses. Now, urinary incontinence is common after radical prostatectomy. One can use a male sling, but I don't like to use male sling a lot because the patient from 4 pads goes to 1 pad. So I actually advocate an artificial sphincter. Now, there's a very interesting concept here. We have a patient, after TURP, the patient becomes incontinent. If you take a careful history, he was leaking urine. After a few months, he develops a stricture. He becomes continent. And if you don't, he will come with a poor flow. Now, if you go and dilate that stricture, he'll become incontinent again. So this history, incontinence, continence, and dilatation has to be taken carefully, and don't dilate these patients. So I'm going to show you my last video. This is about artificial sphincter. And it's our duty to make these patients really continent. As the number of procedures, prostate cancer surgery procedures, post-TURP patients, the incontinent patient number goes on increasing. But I find that not many of our colleagues are offering artificial sphincter to the patient. So the vulvarethra is mobilized, and this is a measuring device to measuring tape to identify the correct size of the cuff, which goes around the bulbar urethra. Usually is about 4.5, 3.5 becomes a little too narrow, and the chance of erosion. I remember that me with Dr. Kirpekar inserted a sphincter in Pune in 1987-88, and the patient had no complaints for 30 years postoperatively. So this is assembly of the area. There are three parts to the device. This is the pressure regulating balloon, which is in the cave of Ritzius. You can make a separate incision onto the inguinal region, or you can go through the external ring, put a finger inside, and this is the cuff, which will go around the bulbar urethra. The cuff is inflated, so the patient becomes continent, and then so the measuring device is taken out. The cuff is placed around the bulbar urethra. The whole system has to be assembled properly without any air bubble inside, and care is taken that there is no infection there. So the cuff size is 4.5. You snap it and then rotate this cuff so that this button goes posteriorly. You can see the inflated cuff there. So this is a small incision just to show you where the vessels are. So at the ring, a small incision is made, external ring, and the muscles are split. And in the retroperitoneum, the pressure regulating balloon, we create a space with the finger. There's a Foley catheter insert at the beginning of surgery, which is left for 1 day. This is the PRB, and the color of the tubing is black. The color of other tubing is white. We close the hole so that the regulating balloon does not come into superficial area. And this is placement of the activation device, creating a space in a subdartos area. And then I'm going to insert this activation deactivation button just below the skin. And then the attachments are used with there is a crimping device. Air is taken out and the joints are joined together with a crimping device. The tubing is placed inside. This is the crimpler. Air is taken out. It could be straight or a right angle connection. Usually the patient stays in hospital 1 day pre-op and 1 day post-op. Then we recycle the device to make that the patient is okay. We deactivate the button and just send the patient home after deactivation. 6 weeks later, we activate the device and the patient becomes continent. The only constraining factor here is cost of the device, which is about 6.5 lakh rupees. So the patient has to spend significant amount of money. But I would say that if the patient has really significant urinary incontinence, then this is the device which will really make him dry. The success rate hovers around 99%. There could be 0.5% chance of mechanical problem like leakage, 0.5% of chance of infection. But I have been very happy with this device. This AMS 800 was devised by Brantley Scott in 1985. And then there have not been a lot of improvements in the device. And all over the world, it is being used regularly. There are some competitors to it now, new devices coming up, but this AMS 800 from Boston Scientific remains the gold standard of the treatment today. So I thank Dr. Arun Chawla, Dr. Sujata Patwardhan for giving me this chance to talk about my favorite subject of post-TURP stricture, which is very common in my practice. And I just wanted to tell you that if you have a patient, I'll give an example. Suppose you have done a TURP We remove the catheter after 2-3 days. His flow is excellent. 3 months later, he comes with a poor flow. Most of us don't do an RGU, but we do a flow rate, we do RGU. We do a small caliber endoscopy to establish the relationship between the stricture and sphincter. And we may dilate him once or twice, but we offer him urethroplasty. The success rate of urethroplasty hovers around 85 to 90%. And then most of the patients are happy to undergo. Because if you have a 60-year-old person, you tell him to do self-care for the rest of his life, is an active life person, he may not like the idea of doing self-care. So I will request my colleagues not to offer self-care to the patients unless they refuse surgery, they are unfit for surgery after multiple failed urethroplasties. Thank you very much.
Thank you, sir. Indeed, we got to see all the types of surgeries which are possible for bladder neck stenosis, and it was really interesting. Very nice videos, and obviously, all being your colleagues and friends, I suppose it was a very good collection of videos which we could see. Thank you very much, sir. And
A few questions
I hand over the mic to Dr. Chawla.
Sir, there are a few questions on the chat box.
Yeah.
First, Shivratna wants to know from you, should DVIU be considered in small post-TURP stricture?
Yeah. For any non-traumatic bulbourethral stricture, so most important point here is that you have to do a small caliber endoscopy with a 4.5 or a 6-inch ureteroscope, establish the relationship between the stricture and the sphincter, and one can do one DVIU. But if the stricture is close to the membranous urethra, because whenever you do a DVIU, you cut the mucosa proximal and distally. So the stricture becomes longer, denser, and there is a chance of incontinence. So if it is away from the sphincter, you can do one DVIU.
Ritraj wants to know that how comfortable we are when we are doing endourology procedure after corrective surgery for post-TURP stricture. He has not mentioned about what endourology procedure, whether it's by cystoscope or TURP instrument or ureteroscope.
Yeah. So suppose he develops a bladder neck, he develops a bladder tumor, then one has to use a little smaller scope and then treat it. It's possible to pass a 24 French resectoscope, but if you pass a 26 French resectoscope, there is a chance that you may cause harm to the repaired urethra. So one has to use smaller endoscope if possible.
So the way you were telling that 26 is actually close to 27 or 28, that means if we plan 22, it should be close to 24.
Yeah. So if there are a few things about it. So in England, when I was doing residency, before TURP, we were inserting the otis urethrotom into the bladder, and the otis was horizontal, and we pulled it out. Suppose I want to use a 26 French resectoscope. We opened the blade up to 28 French and made a full cut urethrotomy. In India, what I do, I pass it obliquely into the bulbar urethra and because bulbar urethra is reasonably wide, and I make an incision through the penile urethra only. But there are some people who use a large dilator initially, but the dilator or passing of a otis is blind. That is fraught with complications. But this may avoid a post-TURP stricture, may avoid.
Anuj from Puttaparthi wants to know that what are the precautions we need to take during TURP to avoid post-TURP strictures? So
my friend Dr. Naresh Rao from Pune, he very rarely gets a post-TURP stricture because he uses, most of us use a 26 French continuous irrigation resectoscope. He uses only the inner sheath, which is 24 French. And now smaller scopes are available, 24 continuous irrigation, 22 inner sheath. For an average Indian gland, which is about 22 to 32 gram prostate, using a large resectoscope is really not required. So you should use only the inner sheath, intermittent irrigation, then the chance of TURP stricture will become less. It cannot become zero.
This question from Prakash. You
Yeah.
demonstrated one case of urethroplasty where you have put one inlay and then one graft which with a mucosal incision which you showed with a ophthalmic knife. So Prakash wants to know how long after the urethroplasty we can do endourology procedure.
So 6 weeks later, you can do that, no problem. So double face is not common. We do mainly ventral-only buccal mucosa graft, which is the commonest operation that we do for post-URP proximal bulbar strictures.
Again, it's some sort of common doubt by Dr. Joseph and Dr. Nishi that do we need to do what is dilatation or routine dilatation before TRP? We can avoid it by using smaller scopes.
No, it all depends upon if you follow your patients properly. Suppose you have done 10 TURPs and one develops a stricture, then there is a chance that you may try next 10 with a Otis urethrotomy to reduce the chance of this 10% bladder, 10% incidence of post-TURP proximal bulbar stricture. You have to follow your own patients. What happens? Now TURP incidence of TURP all over the country is going down, and we don't have really correct data that I did 100 TURPs last year and nobody had a stricture. Something like that, nobody has this kind of data. If we follow the patient correctly, there are definitely number of patients who have a stricture, and if the incidence is reasonable, you have to do Otis. I'm not saying Otis will prevent post-TURP stricture completely.
Yeah, Dr. Philip Raj is continuing his, he wants to clear his doubt whether you really need to make incision with Otis or it's a dilatation.
I think what happens if you make an incision, it's only a mucosal incision, and even if you insert the Otis into the bladder, it does not cause incontinence because it's a mucosal cut. And what happens is that the mucosal cut keeps on bleeding, and the continuous oozing of the blood keeps you keeps the it acts like a xylocaine jelly throughout the procedure and avoids friction.
That's the chat box. Dr. Shatar, you have anything from your end, or shall we sign off? So we had go ahead.
Sir, I wanted to ask you is have you tried this not the robotic but in open surgery, like when the bladder neck was a problem, we always use the transpubic approach, right, sir? So have you done the transpubic approach for the bladder neck, sir?
It's not really necessary to do transpubic approach for post bladder neck stenosis, but
Okay, sir.
yeah, because it's far away from the pubic
Yeah.
bone.
Yeah, another type of stricture, sir, which means recently I have encountered 3 in this last year, is the entire prostate after TURP has closed off at the
Yeah.
level of the bladder neck and at the level of the membranous urethra, and it has become a big fibrous structure over there. No point in creating yeah. So have you encountered, obviously you must have encountered, sir, similar cases where in these 3 cases, I just bypass the prostate and I anastomose the urethra after by approach by both the maze, abdominal and perineal, and I put it on the bladder neck.
But then the patient will become incontinent.
Yes, they were incontinent.
So
Yeah.
there
And
are
so now,
two
yes,
scenarios
sir.
here. One is that after open prostatectomy or after TURP, one can have bladder neck stenosis and a proximal bulbar stricture, which is completely obliterative. And then the prostatic urethra is there, but is completely separated. The fluid has nowhere to go.
Completely fibrosed, yes.
Not fibrosed. It is there. But, prostatic urethra is there, but it's closed at both ends.
Yes.
Okay. Then what I do, I take a DVIU knife and I Just push it without cutting into the center of the blocked urethra into the bulbar portion. And usually the single movement of knife without cutting anything will enter the prostatic urethra. I am not going to make an incision and it goes inside. I'll pass a guide wire. I will dilate that. So sphincter is preserved. Then I enter the prostatic urethra, and from above I pass a dilator through the membranes, through the bladder neck. I make a cut. That cut is so two cuts. Most important is that the distal cut is a cold knife without incision. Just push it inside. But if the whole prostatic urethra is scarred, there is no lumen, then whatever you do, the patient is going to can pass urine through the urethra, but he's going to be incontinent. Whatever you do.
True, sir, because I think sometimes I don't know why it happens and the urethra closes off at both the ends. Maybe there must be some prostatitis going on and a TURP done in that scenario, and probably
It's
don't know the etiology of it.
Common after open prostatectomy.
Open,
I still
you're
say,
right.
Yeah.
Yes.
So there is a
So thank
Joseph Philipper says that good dilatation pre-op will definitely prevent stricture and Otis without knife. Well, I think he is right. He is right.
Talk
Then
of Otis,
Kim Maman says copious use of jelly often is good preventive tip, but copious jelly, what happens? You insert the jelly inside, it dries up very quickly. So the Otis with a cut, the bleeding will act as a jelly.
Yeah, here also, sir, two things here. I have seen people doing using jelly very, what you can say, judiciously and very too much in, see, 15 minutes, take the scope on, inject again jelly, then take the 15 minutes out. I have seen some people doing that. And then Dr. Pilkraj was asking that Otis. So what usually is mentioned is Otis mainly for the dilatation or incision of the appendix sutra. Usually we don't go up to the bulb to use the Otis. So is it the standard practice of going to the bulb, or you just take only the appendix sutra and just open it so that everything
No.
is,
So you pass the Otis into the bulbar urethra, and it is 30 French normally. And then you open it up to 26, 28 and make a cut through the penile urethra. This is common in India. In England, pass it into the bladder and make a full cut.
Yeah, so there's no more question now. Dr. Shweta, shall we sign off? Or?
Yes, sir, whatever you feel right.
Okay, sir. Okay, again for the viewers, just thankful to President Dr. Sanjay Kulkarni for sparing time for Indian School of Urology. Actually, we were lucky to be in his company when we went to Turkey, Istanbul, and we were witness to him being accorded a very highest honor of SIU Felix Cohen Medal. Felix Cohen was the first president of SIU. He was a French guy, and I remember the hall was fully crowded, and we got a lot of tears from all the audience, and we were a part of that ceremony. So with this, with no more questions, and thanks to you again, sir, and thanks to all the viewers, and for you. This will be in the archives from tomorrow morning. If you want to view it again, all the videos which he has shown, you can watch it tomorrow. Thank you very much. Good night.
Thank you. Thank you very much. Thank you.
Thank you and good night. And thank you, Prasant. I hope hope Prasant is here. Thanks, Prasant. Thank you, sir.
Prasant.
Good night.
Thank you, Sujata and Arun.
Thanks.
Thank you, ma'am.